Hey everyone, give me just a second here and I'll be ready to go. Just getting my computer set up, okay?
Sounds good.
Here we go. Sorry, I was trying to get my background fixed, and I think I've done it.
That's cool looking.
Isn't that pretty cool?
Yeah.
Have y'all ever heard of Canva? Yeah,
Yes.
yep. It is. It's pretty amazing, actually. It's a design app that you can make really cool graphics, and they even have like AI things that can make graphics for you. So you can. I typed in "funny brain" and see if I can share what popped up. Let's see. There we go. I don't know if it's gonna work. Well, needless to say, it was a funny brain that popped up. Um, well, how's everybody tonight? Wonderful.
Pretty good.
Everybody get my last email earlier this afternoon about
About class
make,
tonight.
make well, yeah, and making sure that you knew that you've got 3 total attempts for all the weekly quizzes now, just to kind of clear up the confusion on that front, because I know that my syllabus probably said something different, and then I've said stuff different, but um, and that's because I've got 3 different classes and I've tried to match them all, but um, regardless of what has been said, 100% officially, you'll have 3 tries for each quiz. And so, like always, if you get locked out of your, I say locked out, if Moodle messes up in the middle of it, just email me, let me know, and I can open that stuff up pretty quickly. Okay.
Thank you.
Oh, absolutely. Yeah. Well, just so that we're trying to stay with our time here, there's a couple things I wanted to give you the option of. We can discuss, kind of the next step from here is talking about trauma, talking about anxiety disorders, and so forth. Um, and or we can give this an open opportunity for you to ask questions related to practicum, licensure, specialization, or private practice kind of questions. Just because I typically offer two of those every year or every semester, and I've only got one scheduled for the end of the semester, but usually those are pretty good conversations, and a lot of people have questions that are absolutely valid questions, and unfortunately sometimes aren't answered until now. So I'd like to open us up to that as well. So with that being said, I will let you all jump in, and we can get going.
I do have a question about what I know is a school setting, right? So we have diags at the school. So if you're in a private practice or an office setting as a professional counselor, do y'all have like diagnosticians that do stuff, or is that me?
That would be you. Yep.
Okay.
As an LPC, an LMFT, that master's level licensure includes the ability, the scope of practice to diagnose. And it would be, I mean, it might not feel like it, but when you get your license, you will have had way more training in psychiatric diagnostics than even psychiatrists.
Huh.
I know that sounds strange, but in formal training, most psychiatrists don't even take one like official class on this. Like it's a residency, kind of like continuing education, on the job training, where it's just expected that they do know the DSM-5, and there's a lot of them who are I would say professional diagnosticians. But really and truly, when it comes to diagnostics, psychologists do a whole lot of that, like splitting the hairs, whereas counselors are going to do, I would say, the second tier from there, their ability to diagnose, to get going with therapy. And then from there, in my opinion, psychiatrists should be leaning on those other those two sources. Yeah.
Yeah, it feels like I don't know, I guess I'm trying to envision, I don't know if like in an office setting, like, are y'all like totally separate, or do you lean on each other for certain specialties? Do you kind of say, hey, this looks like it's your kind of specialty and what you look at, or you just kind of need to make sure you feel competent in every area?
Yeah, so, and that's a good question. It's going to depend very much so on the context where you're employed. So like if it's a group practice, in most cases, group practices have several counselors, and you're going to have, the off the cuff hallway conversations and the access directly to, your peers for consultation and things like that, which is awesome. There's some folks who just kind of have their own little office cave, and kind of go it alone. And then others will have joined like a multidisciplinary practice, or maybe even a hospital, where, like if it's an inpatient setting, in most cases, they don't expect you to diagnose. That's the psychiatrist or the psychologist's job. Where if you're in private practice in your own group, I mean, it would be expected that you would be, because it's your license, you're treating something that you have diagnosed. So like if you have to go before the state board, it's a matter of, can you prove the medical necessity of treatment, right? And part of that is your own diagnostic conceptualization of that
Mhm.
person's case. Yeah.
And with managed care, are they quite requiring all the time that you have?
A diagnosis, yep, some sort of
And how
diagnosis.
quickly?
If you want to get paid the very first session.
Really?
Yeah, so but here's the thing. I in my initial, even in my evaluations, when I get a referral, whether it's self-referral or through a physician or another practitioner, whatever that referral is will be my provisional diagnosis. So like it might be ADHD or autism or even depression. And I'm just going to put unspecified depressive disorder. I'm going to put unspecified ADHD or unspecified neurocognitive disorder and so forth for my very first session, because that's why they were being referred to me. I'm going to
Mhm.
lean on that clinician's referral. As long as I can back it up with that referral that's coming in or information that we've gathered beforehand, that's sufficient for managed care. And I'm never going to just like, I would never put borderline personality disorder as that diagnosis, even if that was the initial referral, right?
Right. Okay. So it's
'Cause
fluid.
it is very much so.
Okay.
Hmm.
And do you always share your provisional diagnosis with your client?
Not always. I mean, we go through the billing. I say not always. We do always. In fact, if I don't have a formal referral from a doctor, in which
Mm-hmm.
case it would be expected that patient had already been seeking that person out because of that diagnosis or because of those symptoms.
Mm-hmm.
If I don't already have that in my informed consent, it says for billing purposes in our first session, I'm going to bill like either unspecified neurocognitive disorder because I'm a neuropsychologist, or unspecified um, uh, adjustment and related disorder. And so in most cases, that's a non-issue. And it's not like, really what I do is what I'll tell them, I'll say it in the first session is, my job is you're here because I'm a counselor and you're seeking counseling. My job is to help facilitate that process as fast as I can to help you. Part of that's going to be me gathering a whole bunch of information just just to try to put your story together so I can get to know you, which will help me identify, like as quickly as we can, some different strategies that we might want to we might want to journey toward in our treatment planning and in
Mm-hmm.
our goal setting that we're going to have. And during that time, that first few sessions, it'll be a lot of me balancing between giving them space to talk about why they're there, and while also intentionally asking information about their history that I don't already have from them completing their background questionnaire.
Okay.
Yeah.
I guess I'm feeling hesitant or conflicted. I
Mhm.
don't know.
About
About, I just, I don't know if I'm feeling hesitant to label somebody and or misdiagnose. Is that like really
I
naive
see.
or I don't know.
Mm-mm. No, that's a good that
Just
that
being
is a
transparent.
healthy. It's a no, no. I appreciate you sharing because I'm telling you, I would be worried if you didn't feel that way, honestly.
Mm-hmm.
Um, and that feeling really should never go away. It doesn't go away from me either.
Okay.
Um, what I would say is that feeling, you can allow it to guide you toward comprehensiveness and understanding the gravity of of your scope of practice, but also knowing that, hey, it's not expected that I have to be perfect with my diagnosis from the very get-go. And
Mm-hmm.
it's considered a working or a clinical diagnosis. It's going to
Okay.
change over time. And I would say in the majority of cases, it changes over time to where, like, I thought it was depression, but as it turns out, it's PTSD, right?
Mm-hmm.
And I might have diagnosed unspecified depressive disorder in that first session, but session 10, I might switch to PTSD after gathering more information. And
Right.
then it might switch to schizoaffective disorder if that person goes through like a psychotic break or something, right? And so
Yeah.
it's expected that that diagnosis will change. And what I always tell patients is that, these are labels that our brains don't care about. They don't care about these labels. Really, what these diagnoses do is, one, helps us communicate between other practitioners.
Mm-hmm.
And two, it separates us, who we perceive to be us, from a mental disease that is not us. We're still responsible for it, but it takes the shame out of it. And
I like
so,
that point.
in my opinion, sharing a diagnosis can be, and really, and should only ever be in most cases, a therapeutic like intervention, because you get to say, hey, no, you're not crazy.
Mm-hmm.
You've been depressed. Depression is a disease that affects the brain, and we're still going to help you on the psychological side navigate that and develop better skills. Oasis Global UMs. Somebody's requested to record this thing. I'm not really
You
sure.
did in the beginning. Did somebody else?
It says Oasis Global UMM is requesting to record this meeting locally.
It is recording it. We're on 17 minutes and 28 seconds.
No, yeah, no, but like somebody is
Oh,
wanting. I don't know what that means.
She's right there. She's raising her hand. Do you see her? Oasis.
Oh,
This
really?
is
Let me
Mary
see.
Mereti.
oh,
Hello.
Fine, thank you, sir. Sorry, I ran late.
Were you trying to record this?
Yeah, I'm recording it. I click here, record, and they were saying request. So I just did request, but forget about it.
Yeah, because I'm recording it on my end. That
Okay.
way everybody will have it.
Okay.
Sorry, I was like, man, I'm getting hacked. Somebody's hacking into my computer. I've never seen that pop up before.
That
That's
happens.
interesting.
For
Yeah.
sure. Okay, I have one
So
more and then I'll leave it alone. So
no worries. And well, just one more thing was that
yeah.
don't don't be afraid to take calculated risks in the diagnostic side in consultation with your peers, especially. So, like,
Okay.
when in doubt, reach out to other peers
Mm-hmm.
and kind of get a sense of like, hey, I'm not going to share all the PHI here, but here's kind of the case details.
Mm-hmm.
I'm leaning, this way, or I'm concerned if I say this for billing purposes that it might affect them in this way. What do you think? Because everybody's different, and there are times that I won't give a diagnosis from the very get-go because I know this person might be applying for like a security clearance position, through
Right.
the government or something.
Right.
Yeah.
Do you ever see clients like when you give them a diagnosis, they like go and search every symptom and like a self-fulfilling prophecy, and then they start identifying. I mean, I know that's like out of my control what they go do with it, but it is a
Sure.
concern in my brain. That's kind of part of my fear too.
I've never had a patient that my diagnosis was a surprise to them.
Okay.
Like,
Yeah.
meaning there are times that they've had it confirmed and have taken it from, you know, from me giving a diagnosis to researching it and coming back and being like, I like there feels like a weight off of me. I feel like I finally get it and understand I'm not alone either. It sounds like there's a bunch of people that have the same kind of stuff. Like
Yeah.
that has been my experience,
Okay.
like way more so than anybody like coming in just and then me telling them a diagnosis and then it kind of being the what's called iatrogenic. Have you ever heard of that before?
I have.
So iatrogenic symptoms are where you don't have symptoms until somebody tells you that you're depressed,
Yeah.
and then now I'm going to have depression
Right.
symptoms. Yeah.
Yeah.
Yep.
Okay.
But that
But
doesn't
the
happen
majority
as
of the time, I mean, when they're ending up in your office, it's almost just a relief and a confirmation. And,
it is the majority. Now, I'll tell you this, since TikTok especially,
oh yeah.
there's a lot of people who come in who have previously researched this stuff a whole bunch, or at least when I say research, they have listened to a lot of influencers uh, talk about what may or may not be an accurate thing for them, but they have accepted it as a diagnosis prior to even being diagnosed, and then sometimes that does not align with my opinion on what their diagnosis is, and that's been more difficult to navigate than
Mm.
what you were talking about.
Okay.
But in that case, what I tell everybody is our diagnostic manual has an arbitrary cutoff of number of symptoms in order to make a diagnosis for any of this stuff. And on top of that, it has to affect us functionally. So like I could meet all the autism criteria, but if it doesn't affect me functionally in the same way that the DSM would highlight, then that's not a diagnosis. Yeah, I've got more traits for autism, but it's not an official diagnosis.
Right. Right.
That's what I've been trying to explain to all the teens that come in who are convinced that they have autism, and they get mad when like somebody says, you know, tries to dismiss them. And I don't blame them because they've done a
Mhm.
lot of research. They've memorized that stuff. But like I tell them is that, listen, these aren't hard and fast rules for diagnostics. They're going to change over time. So you might seemingly qualify right now, but because it can shift over time, what matters the most is, does it help you understand yourself? And do you even need a diagnosis in order to use it?
Mhm.
So I can understand my sensory processing difficulties from an autism perspective, even though I know I don't have autism.
Right. It does seem like the youth, they're using, so it used to be they would call each other bipolar all the time, and they used it
Uh-huh.
very freely. And now it's switched to autistic. Dude, you're
Autistic.
so autistic. They throw it around and they really are into it. It's weird.
Well, there's
The TikTok.
a there's a group of teenagers, young adults, and adults who feel isolated socially and who have always felt isolated socially,
Mm,
who now have something that assigns them an identity, which puts them into a group of other people similar to them. And so,
yeah.
from an existential standpoint, it helps them not feel alone.
Yeah.
That's why they fight so hard against that. Whenever I say that they don't have it, that doesn't mean they can't find community around
Right.
people who have official formal diagnoses. But there's some implications that come with those diagnoses, like the fact that autism is supposed to be a lifelong thing. And actually, let me ask the class this real quick, because I know there might be other questions, but this is a good point. Autism, we would all agree that this, you know, it's implied as an is a lifelong diagnosis. The DSM-5 implies that it's a lifelong diagnosis, correct?
Yes.
Right. Now, when you read through like the diagnostic criteria, does that mean that every single day of that person's life, they meet the full criteria? They meet the diagnostic threshold?
Probably not.
So there are some days that they don't have autism, right?
Mm-hmm.
In the same way that, like, if I have ADHD and it shows up functionally whenever I'm, I'm teaching full time, I have a practice full time, I have kids, I'm married, like, if it shows up now, but if I became a billionaire and like I just bought my own island and I just moved my family out to this tropical island and we didn't have to do anything, just, watch surfers all day, I would no longer have ADHD, even though I've got an ADHD brain. It's supposed to be a lifelong condition, right? Yeah. So see how, I guess, the validity of these diagnoses matter the most as it relates to describing why we're having difficulty in the here and now, and perhaps in the past, and predicting what might be our difficulties moving forward. Because if they're not real great at that, at predicting, especially, in my opinion, it's questionable if that diagnosis is going to be a lifelong thing or not. So I personally don't believe that autism or ADHD are necessarily lifelong diagnoses officially.
That it gives a lot of hope.
It does. And I would have a lot of autism specialists right now. I can see their face turning red and they're clenching their fist in argument of that, because I'm not saying that the brain loses its autism. I'm saying that their autism is going to possibly improve to the point that it doesn't affect them functionally enough to make a diagnosis anymore.
That's awesome.
And it's not about not making it. That's not the goal. The goal is just for life to be easier, right? The goal is to not have anxiety, to not have sensory processing challenges that interfere with your ability to work or have relationships or go to school. Yeah.
I think school is probably one of the hardest settings. They must all improve when they get out of that school setting. I mean, I see it daily, the stress it puts on them to function in that environment.
Yeah.
Our individuals with autism, it's just tough. It's a tough place to be. It's a tough place to be when you're not an individual with autism.
Ironically, though, whenever they first graduate from high school, there's quite a bit of risk for a lot of those folks, including ADHD, to experience their first depressive episode, their first manic episode, or their first psychotic episode.
If they don't have the structure and the social.
It's a disruption to routine and a newfound freedom to withdraw and to isolate. Yep.
Interesting.
Can I ask a different question?
Yeah.
But Beth, I love what you just asked him. I learned a lot in his answering. So thank you for doing that. So I really, really, really want to hear your lecture or some information from you on trauma, because Dr. Armstrong, you give such good information whenever you do talk on a topic. But really quick, can you please tell me, so I just saw this new CPCE exam pass requirement, blah, blah, blah,
right,
from Amberton before we go into a pre-practicum. I don't even want to discuss whys and everything. I'm sure they have their reasons. The question I have for you is the practice test that they're having us take, and they gave us the dates for them. Like, you got to kick one of these in before you go into pre-practicum.
A lot of y'all are going to be grandfathered in, though.
I'm not.
Okay.
I mean, I have 3 classes left, and I'm not. But they will make concessions, because I brought up other issues to them about, you don't understand. If the test is on this day and you have to have all of these courses done, how can you get it completed and get your grade back to know that you had a passing grade? And so anyway, they're willing to work with you. So I'm not worried about that. but here's the question. This practice test, will it show up somewhere in a system like, oh, you took it once and look, you didn't do, but y'all have it. There's administrators that are involved in giving us this test. So how does that not get recorded somewhere? For
As your
y'all?
data collected there? Yeah.
Yes.
So for us at a school level, we will have access to who's taken it, what their score was. That information, the scores will get shared to a database of like everybody, like the whole, whoever takes it, but your name and like your identifying information won't be shared with that far.
Okay, but that's only in Amberton. In other words, this is not going at a state level. This is not anything that's ever gonna show up.
If you like apply for a job or like, well, you have to disclose, like I took the CPCE
Sure.
like 4 times.
Okay, because
No,
like when you take in the olden days, when you in high school, when they would take ACTs and SATs and all that stuff, that stays with you. You need to like know your stuff before you take it, because it could whiplash back at you. That's what I don't want. That's why I'm asking about this, because I need completely to know different. Fully what I'm getting into.
So the NCE like would stay with you.
Okay.
Right. So like if you took the NCE 4 times, it could possibly show up, with people having access to that information. Not always. Like, so for example, even my licensure exam, we had a practice licensure exam as a kind of like what we're doing now with the CPCE, as a master's juncture, or like a capstone achievement, right?
Yes.
And we could take that thing, a million times and not pass it. But with the EPPP or with the NCE, the state level, they keep track of who's taking it, and then how many times have you taken it.
Right.
Nobody else has access to that information unless you give it to them. So like, even like down the road, like 10 years from now, an employer says, well, obviously your license, can you send in your NCE scores? Well, as far as I'm aware, you're only sending in your most recent NCE score.
And why would anybody take it multiple times unless they were trying to get a better grade, right? So, so that would be the logic in sending in the most current one.
Right.
Okay.
So
I just wanted to make sure.
Nobody would ever have access to that. Yeah.
Okay. I just wanted to make sure that this Amberton thing, that is a pre-practice, whatever test, is not going to be one of those, oh, we didn't tell you that that's going to follow you, because I'm actually thinking about taking it, even though I feel ill prepared, and I'm getting the book and going to start studying, but I want to take the September 21st, because guess what? If you don't make the 66 or whatever the grade is, and you have to take it again, guess what? The next one is in December. Because practicum's rolling around for me. And if I don't get that knocked out with a safe grade, I can't enter the pre-practicum.
And you guys are kind of y'all are in the hardest cohort. Yep. Well, just because y'all are the first ones to go through the change.
Yep.
People behind you will be much more prepared from the get-go to anticipate it. But here's the thing. Don't worry about it. Worry about it enough to study. What's awesome though is that the more time you spend on this right now, the less time you're going to have to spend when you take that NCE.
Okay.
And so it's not like you're going to be having to do twice as much work. We're actually making it easier on you just by forcing you to study for your licensure exam right now.
Right. I mean, I understand that, but when you've mapped out, these are the courses I'm taking, this is when I'm going to take it, this is what's going on in my life with my kids and work, I mean, everything. You know when to slide in a harder and easier class. And so throwing this at the last minute was kind of really irritating. But
Yeah.
I'm not gonna waste my time. I'm just gonna move on and do what I gotta do. I just wanted to make sure, I just wanted to ask you that one question.
Well,
And so
Donna,
thank you.
I can assure you, because we just had a whole division meeting about this, and I can assure you, all of us full timers are approaching this in a way that we want to support you guys, and we're not trying to make you extra stressed out. And we will work with you to do everything we can to help.
I already met with the director in Frisco office, Hodari, I think is how you say his name. Anyway, he's a director over at the Frisco location.
Okay.
Great. We'll work, same thing like you. We'll work with you. We could make an exception. We understand that you're kind of caught in a groove here where you can't have finished all of these courses perhaps. So yeah, I think they're being great. So I'm not worried about that. But thank you for answering this, that it's not gonna show up somewhere if I do horrible. I'd rather attempt it and know what I'm really getting into and have another chance to take it again if I have to.
Yeah. Well,
Okay.
and really, I don't know who Udari is. I don't even know that name.
Okay.
I'm sure they are who you say they are, but really your person of contact would be Dr. Ken Johnson. He's the department chair.
Yeah.
And we are all on the same page.
Yep.
We're not going to stress y'all out. I promise you, you're going to do better than what you think. The people that are worried about it are the ones that are going to do the best. The ones that that we don't hear from right now, that aren't frustrated, those are the ones I'm worried about, honestly. Because
okay. Yeah.
Oh, go ahead. Yeah.
I was just thinking, well, can our grades just you can become exempt from something because of your grades, but it's all right. I mean, it's going to help me and I'm going to do it. And it is.
So was it created due to like a number of students not doing well on the NCE? And so.
No, we used to do the portfolio in the pre-prac class where you would have to do a case vignette. You'd be given like a case vignette, and then you'd have to make like a diagnosis and a treatment plan and all that stuff. And then you'd have to write another paper that outlines your personal counseling philosophy, and you put those together, and that's your portfolio. We wanted to move away from what that was, which was a very subjective grading process, to more of an objective, like measurement, quantifying like actual performance, and then being able to use that data to correlate with future licensure exam grades and to track progress better of students. Because it used to be just us reading your case vignette. It would go to two of us, and two different full-timers would read the portfolio and either say pass or fail, and if we disagreed, it'd go to a third full-timer. And that we had an outline how to grade it, but it wasn't objective in any way. There's no way we could use that data to monitor and improve the program or anything like that.
Yeah, I think it's good because I took the NCE dry, for lack of a better word, and
yeah,
if it can prepare them, like if it's set up in the same way, because it is not a very straightforward. I'm not trying to scare anybody. Everybody will do fine, but it's not a straightforward exam, and you got to read those questions like 6 times. So if you can take something similar, and when you walk out, you're like,
I've never heard of
happened?
anybody.
I've
never heard of anybody that was like, "Oh man, I just knocked that out of the park." Nope.
Yeah, I mean, I sat with my envelope forever. I was scared to open it. So it's, if it can, Donna, give you any, that is stressful at the end. I totally get that. That's hard when you've planned everything out. But if it gives you somewhat of an idea, then really.
Okay. Well, and I think practically too, spending that time studying for the NCE, for the CPCE, can go towards the NCE, using that time instead of the time spent making a portfolio that you're never going to ever use again.
I agree. Yeah. I like that.
I agree.
Well, and it, like you said, it also helps give Amberton feedback, because I know y'all used to tout that y'all 90% of the students who took the exam passed it, and maybe it's not as
It's
many
like
people
98%.
passing. Huh?
No, we still have a high, it's still like 95 to 98%. Mhm.
Really?
That's awesome.
Yep.
That's pretty good.
But we've got unique students where y'all are motivated. I mean, honestly, we do. Y'all are much more motivated than most folks coming right out of undergrad, which is
Because we're
where the,
older.
yes. But I will say this though, I walked out of my licensure exam in the same way, feeling I was like, yeah, gonna have to retake that thing and I was at the 99th percentile on
Wow.
my score.
You
don't
did
let-
hit it out of the park. Almost.
I'm telling you, and it doesn't matter who you are, if you spend time studying, you will do exceptionally well on the test.
Okay.
But you're not gonna feel like you did exceptionally well.
Okay. Thank you. Tell
Well,
us about trauma
Yeah.
and the brain, or
Let me pull
whatever
up.
you teach on trauma. Is there a chart
Mhm.
deck we should be looking at? We should be.
Well, sorry, had a snack because I haven't eaten like since 11 today.
Wow.
Yeah, I'm gonna pull up week 6 PowerPoint slides. It should be
Okay.
week 6 and 7.
I killed a tree, but it doesn't matter because these are good notes.
Well, I don't ever make PowerPoint slides the way I make them because
I love them because I can read
exact
them.
opposite.
That's how I found a lot of my test quiz questions, is by reading through the chart decks.
Mm-hmm. I can always tell who has that. Well, actually, Moodle tells me every time you even look at Moodle, I think it tracks your eyesight, because it tells me like every activity that everybody does. And so like when people at the end of the semester are like, why do I have a B? I did everything. And
What do you
if it
mean?
comes down, well, like if they're like 1 point away from like an A.
No, I mean, what do you mean it tracks your eyesight? What are you talking
No,
about?
that was just a joke. I'm just saying, like,
okay. My
I'm so
husband tells me
sorry.
I don't know how to take a joke, so I got you. Okay,
I'm so
like,
sorry.
what?
No, that was a joke.
I'm gonna close that thing off. I'm not gonna let it see me anymore.
No, but he'll tell me if you clicked on like my slides, if you downloaded them, if you watched the the link that I send, that kind of stuff. So let me share my screen real quick.
Did you add this in later, or because you're saying week 6 and 7?
Uh-huh.
So
Do you have these slides here?
Yes, those
Yep,
look
that's
familiar.
it.
Thank you.
That is it. Yep. Yeah, so we've got about 15 minutes, and so I will give you a rundown of trauma. And I love our profession. I love our professional peers. We are an anxious bunch, though, and I'll say that because there's a lot of like movements and like passionate movements in our field from time to time that I've noticed just over time, and we're in the movement right now of everything's trauma informed, right? So everything is trauma aware. And part of me just wants to say, if you weren't before all this, like, what were you doing? Because we all, including, everybody like psychologists and professional counselors and elements, we are all and were trained in the sense that trauma is a real thing that is essentially present with everyone on a spectrum. I mean, from a biological standpoint, and I'm not trying to say I'm glad that we're becoming more aware, that we're emphasizing that, but it seems like we're in an echo chamber. We're like telling it to ourselves, like, well, did you do that trauma informed, or did you do that kind of judgy towards each other, rather than us being as a group and saying, hey, medicine, maybe y'all should be trauma informed, you know? Hey, all you neurologists, all you psychiatrists, all you, orthopedists, are you trauma informed? Right? But that's just my soapbox, just because, there's shifts and it's like, if you don't just jump on the train, everybody gets mad at you. But you don't have to be an EMDR specialist to treat trauma. In fact, the vast majority of people treating trauma don't have a certification in like trauma. But you're going to treat trauma whether you like it or not. It is a fundamental part of all that we do, because our brain is wired to learn the most effectively from things that possibly could interfere with our survival. So in other words, I can tell you, I'm so glad that I cannot remember being born. Aren't you? Y'all are glad?
Yeah, that would be traumatic to
Right.
know that.
I cannot consciously.
Yeah.
Now here's the thing. But you better believe that there's a part of your brain that has that memory, that trauma memory, stored in there.
I believe that.
In fact, there's been some research to show that like the sedating effects sometimes of C-sections, that make it to the baby,
Sure.
can influence like attachment style and even like risk for like anxiety. In other words, decrease risk.
Really?
Right.
Because the baby didn't come out at its own time, and
it wasn't as traumatic.
They were sedated.
To be birthed. You're right. And from a sedation standpoint, that's actually the same finding that they had with veterans, where veterans who were injured like in combat, while in combat, they had a med person there that gave them morphine for pain. Those veterans ended up developing trauma at like twice, or like way, way, way less than their peers who never had morphine in the field.
Oh, I understand what you're saying.
It's interesting, because what that means is there's a biological, obviously a biological component, but at the time of trauma, the state of your amygdala, the state of your brain matters.
Okay.
And it matters because any medication or anything that disrupts in that moment your ability to remember something. So people who take like benzodiazepines, for example, like Xanax and things like that, or another example would be Rohypnol. Now, roofies, which is Rohypnol is very similar to benzodiazepines, just so you know. It's an amnestic. It causes people to still be alert and walking around talking, but they're not laying down new memories. And I'm not saying people who are the victims of the date rape drug don't have trauma, but their trauma is going to hinge on the effectiveness of that Rohypnol that whoever their perpetrator used in relation to the symptoms that they're going to have acutely. And I'm not saying, please hear me out on this. I'm trying to be sensitive, but also just
that makes sense.
Biological facts, right? So a lot of times those victims have trauma, but even though they don't remember consciously what happened. And my point there is that you can turn off the autobiographical memory side. That's the part that says, oh yeah, yesterday I had a hamburger for lunch. You can turn that off much easier than you can turn off the baseline recording, which is the right amygdala, the right hippocampus. That's the part that where people are driving down the road and for no reason out of the blue, they have a panic attack. They don't know what the trigger is, right? You've probably heard stories of people like that. I was at Walmart and I just started having a panic attack. I have no idea why. Well, if the heart stuff is ruled out, in a lot of cases, there's a unconscious conditioned stimuli that was traumatic for that person that they're not aware of. And do y'all remember, was it Baby Albert? Did you ever watch those videos? Yeah, if you've never watched those videos, let's see if I can at least share the link. You need to read about
anything white and furry. Is that what you're talking
goodness
about?
gracious. Yep. Little Albert, that's his name. They messed this kid up.
Yeah. And talking
terrible
about those victims, it makes me think of, you know, it's so important that, and it makes me even think about and question forensic interviews. You know, not everybody asking the victim what happened or telling them and filling them in on what happened. You know what I'm saying?
Yep. And
Because
how
they
much
may just be telling them the narrative that they don't remember.
I was in that big forensic case last semester that finally just got noticed was settled, thankfully. So I don't have to mess with it anymore. But that was a big part of my job, was differentiating between what these kiddos had been told by their parents versus what their actual memory of the events were. And there's a big difference.
Yeah.
In fact, one of the kids had no memory at all, but like readily admitted, and I love little kids because they're just honest. Readily admitted was just that, no, that's just what mom and dad told me happened. And that's terrifying. So y'all see this right here? So the little Albert experiment, the idea is that there's classical conditioning that takes place in the experience of trauma. Now, let's real quick define the difference between classical and operant conditioning. Who can tell me that? Does anybody know?
Between classical and what?
Operant conditioning.
Probably not very well.
So the best way to think about this operant conditioning is reward. So like if I want my dog to roll over, which is not actually that's a bad example. If I want my dog to stand on his back legs and hop around in a circle, that is not a natural behavior built into their brain. Everybody agree with that? I've never seen a wild dog doing that. Only dogs who have been trained will do that. And so the way they trained them was eventually they gave them rewards every time they started to approximate that behavior, eventually just shaping it such through reward to get there. That is operant conditioning. It's reinforcement. It's positive, negative reinforcement, and punishment, using punishment and reinforcement to shape behavior. As compared to classical conditioning, which is the ability, like if I wanted to make you blink every time I whistled, like that, well, you know what we would do? Blinking is already built into the brain. You blink all the time, correct?
Yeah.
If I could take like a little Q-tip, like a little cotton swab, and I could whistle and then touch your eye and make you blink. If I do that enough, eventually I don't have to even touch your eye. I can just whistle. It's going to make you blink. That's classical conditioning. Or the Pavlov's dog. Y'all remember Pavlov's? Does the name Pavlov ring a bell? That's the joke.
Ha! I didn't get that either. I don't get jokes, I suppose.
So Pavlov, well, I'm not very funny either, so that's okay. So Pavlov, right? He had a dog that would salivate every time he fed him. He didn't have to teach the dog how to salivate. But what he wanted to do is see, I wonder if I can make him salivate without food, but just by ringing a bell. So what he started doing is he would ring a bell, present the food, the dog would salivate. Ring a bell, present the food, the dog would salivate. Eventually, he could just ring the bell and the dog would start salivating, anticipating the food. That's classical conditioning. That's what happened to little Albert, and that's what happens in trauma, by the way.
Oh,
The trauma response is a classically conditioned response where it is built into your brain to have a fight or flight reaction when your life is threatened. Okay? What diagnosable trauma is, according to the DSM-5, is that's the natural reaction, but when that natural reaction extends and continues despite you not being in that situation anymore, and when it starts to get generalized to other similar situations and interferes, this is what it hinges on, interferes with daily functioning, that's when it becomes diagnosable.
ah,
Can you clarify trauma in reference to PTSD? Not everybody that has trauma has PTSD, correct?
I would 100% say you are correct. Yep.
Okay, so there's, like you said, different levels of trauma. And so just because somebody has experienced, even if it's a severe traumatic experience, which can be subjective for each individual, but anyway, it's not, they won't necessarily have PTSD.
Right. So PTSD is a made up set of symptoms. Again, it's arbitrary cutoffs here that we're saying people have to have met all these criteria in order to be diagnosed with PTSD. Because they did that from a legal standpoint, because there has to be like a line that they've got to have draw somewhere. But that doesn't mean that people who don't meet that full criteria don't need treatment of their trauma, because they do. I promise you that.
Yeah.
And that line that they draw is ever moving because it might change the next revision of the DSM, you know? And so which one's objectively? Is it us just making stuff up, or is it the brain and how we're trying to make these things concrete, categorical, where they're not? It's much more of a spectrum.
Right.
But
is the treatment quite different? Or
if it's diagnosed or not? Nope, not at all. In fact, that's where EMDR therapists kind of come in and say, hey, no, even if we don't have official diagnoses of trauma, when somebody has a memory that they would subjectively label as a traumatic experience from a psychological standpoint, that doesn't mean they have, PTSD, but it does mean that they probably have a traumatic memory that has been conditioned classically, or that has classically conditioned and generalized, possibly interfering with their current relationships or current, I'll give you an example. I had a patient once who at like 9 years old had a car wreck, or was involved with a car wreck that was pretty significant, but not like nobody died. And then at the age of like 30 something, started having panic attacks. They had started a new job and they were having to drive really far in like a lot of traffic, started having panic attacks or a trauma response while driving, even though it stemmed from way back in their past, and they didn't have like recurring nightmares at night. I mean, it wasn't necessarily hypervigilance and all that stuff. So they didn't have PTSD, but there's no doubt that trauma experience was remembered in the brain. And for whatever reason,
physiological. Yeah.
Yep.
Interesting.
Yeah. And I am going to have to wrap this up, but I want to say a few more things and then then sneak over to my next class, but trauma has, or I'll say this, psychological stress and fear and the fight or flight response is a survival response that we all need and depend on every single day. There's a spectrum to that response, and there's a difference qualitatively and even quantitatively. You can look at blood pressure and heart rate compared to like somebody like if you almost had a car wreck versus, hey, you might not pass this one quiz, right? Your fear and your anxiety is going to be qualitatively different, even though it's eliciting physiologically similar responses also on a spectrum. But what happens is that your brain, there's an unconscious part of your brain, the limbic lobe. That's the emotional processing center, right? It's the amygdala and the hippocampus. Those two parts of the brain are always looking for every perception that you're allowing into your brain, even your own thoughts, to try to figure out, to try to improve your survival skills, basically. And so when we have an anxious disposition from the get-go, from a genetic standpoint, and by the way, the higher the intelligence goes for most people, the more anxious their disposition is. Just FYI.
I must be a genius. No, I'm kidding.
That's great. I love that. I'm gonna start saying that.
I'm gonna go tell my husband
that's how I
that.
found out. That's how I ended up in Mensa. But
Wow, that's cool.
well, and if you think about it this way, the more your brain's able to process at an earlier age without the ability to prioritize and filter it the way it should because of the frontal lobe developing age appropriately. In other words, people with high IQs, they've got a brain that can process and think more abstractly with more information than most of their peers. But developing a developing brain, though, their frontal lobe isn't fully developed until they're 25. Even if they don't have ADHD or anything else like that, they've got more that they're asking of their frontal lobe than their peers. In a lot of cases, that much more thoughts causes increased stress. And I'd love to see this research done, but I guarantee you that's tied to an increased prevalence of anxiety disorders in adulthood.
Wow, that's huge.
And so the last thing I would say about PTSD is PTSD and trauma, well, the diagnoses hinge on this concept. Our brain is supposed to forget things that are no longer relevant or important or applicable, right? So like if, for example, let's say, I'm trying to think of a good example of this. Yeah, like if, yeah, let's say you experienced like a severe, tornado storm as a child, and then moved as an adult, to Hawaii where there's like no tornadoes, but there are storms. The brain wants to remember that tornadic storm because it does not know logically that Hawaii doesn't have tornadoes. But the problem is that memory of that tornado, even unconsciously from an emotional standpoint, can be so powerful that you can't control it consciously whenever you get to Hawaii and you're thinking about, well, this is not a tornado, it's just a storm. But it still is going to ramp you up, still cause you hypervigilance when you hear thunder, right? That's the diagnosis of PTSD, except you got to add the threshold of almost or being exposed to something that threatens your life, in addition to several other symptoms that go along with the acute stress response. So if you've never had a chance to look at it, you really should look at Robert Sapolsky's stuff. I think the video might be in our class. I'm pretty sure it is. I'm in week 6, I believe.
It is
But
he
Z
also-
or S.
Yep.
How do you spell it?
Zapolsky.
Yeah, I'll let me put that in the chat.
So is there success rate in, like, it feels like that childhood trauma is like hardwired for so long. I mean, how do you unhardwire that?
Well, and that's the thing. Do we want to?
Right. Well, I mean, if it's still serving them, maybe not. But if it's not serving them anymore, I don't know. It's
Well, and that's where like explaining to our clients, like, listen, your brain isn't broken because it's doing this. The world we live in is broken. Nobody on the planet should have gone through what you went through. You're having these symptoms now because your brain is still trying to protect you, even though you're no longer in that situation. We just happen to also call that a disorder. And if you look at it from that perspective, it's not a matter of, I don't want my brain to turn that off, because, hey, if I'm ever in that situation again, I want to not have to think consciously to escape. I want my body, my brain to be like, to be able to override my judgment.
Right.
And so we're not going to get rid of that, but what we can get rid of, we can decondition that person so that, it's no longer they're avoiding driving, because of the car wreck. They're able to sit in a car or ride in a car or get on the highway and drive, because they do need to do that, and they do want to do that. Does that make sense?
Yes, that's so good.
So the trauma is going to be the treatment is going to be targeting how does it affect them functionally, not so much of we're going to get rid of this trauma or the memory. It's more so that we're going to decondition those symptoms.
like the hypervigilance, like getting that come down. Yeah.
Allowing both our conscious and our unconscious to be much more in balance, and not just our fight or flight.
Right.
Yep. All right. I'm going to stop
Can
this.
you spell the guy's last name,
Oh,
Robert?
yeah. I'm sorry. Yep.
It's okay.
Sapolsky. Yeah, Robert Sapolsky, and he's the one who wrote Why Zebras.
Oh, yes, I understand. I saw that in the
Ulcers.
information. Okay.
And there's another
you.
book that I'm about to start reading. Because I've heard it's really good too. If you ever get a chance to watch him, he's actually really funny too. I mean, he's the most like California like professor from the 60s that never left the 60s. I'm telling you.
Cool. What's the other book you're reading? Sorry.
It is,
because I know we're gonna lose you.
What was it? It was it's in my, I'm glad you're making me do this because I had it in my Amazon cart. It is called Behave: The Biology of Humans at Our Best and Worst.
Oh, cool. Humans at our best and worst.
Mm-hmm.
Thank you. I love when you lecture. You have so much good information in that brain of yours.
Well, I don't know a lot of, well, I'll be honest with you. I had really good professors that were passionate about this stuff too. And I remember sitting in there and just being like on information overload, but also just like, I love it so much. My hope is some of the tidbits that I'm throwing out there will inspire you to be like, I wonder what that's about. And you go, and that's what happened with me. I just went, I started just researching everything in, looking it up and like reading, like didn't even know who Robert Sapolsky was until we watched a video when I was in grad school of his very first work. And then I found his book, Why Zebras Don't Get Ulcers. And I read that. And then I looked in the credits of that and found other books. And it's just, it takes you on a journey through that process. And that's my hope is hopefully some of my nutty professor ramblings are doing that for you. So
Thank you. It's well
absolutely.
worth when we can. So next Monday?
I believe so. I think we're back on our schedule next Monday.
Yeah.
Yep, the 24th.
Yeah. I'm gonna
Yep.
miss you. Sorry. My mom, 1 year passing, going to San Antonio.
No problem. And I'll have it recorded and we'll make sure to get that
Awesome.
uploaded too. Okay.
Thank you. Bye,
Yep. Y'all have a great evening. We'll see you
Yes,
next
bye.
week.
Okay.
Repeat
you.
that book, Professor Armstrong.
Uh-huh.
Repeat for me that book you say that is biology, the one which you have said. Huh?
Yeah, it's called Behave.
May I write down?
The biology of humans at our best and worst.
Human.
Yeah.
Mm,
And here's the link to the Amazon.
okay. Thank you.
Absolutely.
Yeah.
There you go.
Okay. My copy it before you go.
All right. We'll see you next week.
My copy that.
All right. Take care. I gotta end it.
I'm trying to copy the link. Okay, there you go.
Awesome.
Now I have copied. Thank you.
For sure. We'll see you next week.
Awesome. Bye.
Bye-bye.